Hello and welcome to the second installment of the Transplant C-Suite Webisode program. This edition focuses on Medicare reimbursement for organ acquisition. We're pleased to be joined today by Mr. Robert Howey. Mr. Howey possesses more than 23 years experience in the healthcare finance industry. He's currently a senior director at Toyon Associates, a firm specializing in government reimbursement located in Concord, California. Prior to joining Toyon, Robert was a manager at Mayo Clinic for 13 years, overseeing the government reimbursement and cost reporting function across the Mayo Clinic enterprise. Mr. Howey is a licensed CPA in Florida and earned his BBA, MBA, and MHA from the University of North Florida. Robert, it's a pleasure to have you with us, and at this point, I'll turn it over to you.
Okay, thank you, Corey, and thank you for everyone for joining this call today. So my goal with this presentation is to provide awareness of a highly complex and often misunderstood area of Medicare reimbursement. So the topics that we're going to discuss are the current landscape for solid organ transplant programs, the Medicare reimbursement methodology for organ acquisition, and what are those financial risks to transplant centers, the key Medicare reimbursement drivers, and what are the keys to financial success for a solid organ transplant program. So first, I think it's important to talk about what is the landscape for transplant programs. This is a unique service line, and it's not common in many hospitals. So roughly there's 3,400 acute care hospitals across the country. And only of this subset, 2,800 are considered disproportionate share hospitals, meaning they have a high ratio of Medicaid patients within their organization. And there's a separate add-on payment for Medicare for that. The next subset, about 1,100 teaching hospitals, so another specialization focusing on areas of Medicare reimbursement. Now we switch to transplant centers, and there are only roughly 200, and this includes both adult and children's teaching transplant centers within the United States. So the area is very complex and it's often misunderstood. Transplant, unlike other service lines, is also heavily regulated, not only with CMS, but also with UNOS, the United Network for Organ Sharing, that manages the transplant waitlist. And there's separate reporting requirements under the Scientific Registry of Transplant Recipients. With respect to the Joint Commission, there are separate conditions of participation to remain a transplant program with CMS, separate from the hospital conditions of participation. So let's go over the Medicare reimbursement methodology. The reimbursement is obtained through the Medicare cost report, and it's a cost-based reimbursement methodology. Medicare will be the single largest payer for solid organ acquisition costs. For example, in 2016, assuming these costs were properly reported, but Medicare did reimburse $1.6 billion of roughly $3.3 billion claimed for organ acquisition, or about 48%. Medicara's reimbursement is based on their share of Medicare to total usable organs, and we'll go into that in more depth a little bit later. Now, we're not going to wait until the end of the year to obtain reimbursement from the Medicare cost report, so hospitals will receive some interim biweekly payments, and they're just based on projections of what those costs will be in Medicare's ratio of those costs at the end of the year. A final settlement does occur within the Medicare cost report that's filed five months after the fiscal year end. Now we have a good understanding of what our costs were for that year, as well as what was our organ count and what was Medicare's ratio of that organ count. So what are organ acquisition costs? So generally they represent the necessary and reasonable, and I underscore necessary and reasonable with respect to Medicare reimbursement. This cost is attributable to acquiring an organ and preparing the potential donor or donors and transplant recipient for organ transplantation. There are three components of organ acquisition costs, and we'll break those down here on the next few slides. So the first and the largest component of organ acquisition costs include direct hospital costs. The first one is going to be the organ fee. This is going to be the largest of those direct hospital costs. So this is the fee charged by the organ procurement organization for acquiring a deceased donor organ for transplant. These may range between $30,000 to $45,000, depending on your particular OPO. Transportation costs associated with receiving that organ, as well as the organ retrieval team, are allowable organ acquisition costs. Registry fees to place your recipient on the UNOS waitlist is an allowable cost. Tissue typing between recipients and donors, physician pre-admission evaluation services, surgeon procurement costs related to deceased donor organs, and then the pre-transplant administrative costs for just operating a transplant program with your institution. The next component of organ acquisition costs are the hospital internal services. So services that are provided within your particular facility that are related to organ acquisition. Common components include the inpatient live donor nephrectomy related to the live donation, pre-transplant diagnostic services for prospective recipients and live donors, irrespective of whether they would donate or whether they even receive a transplant. A post-transplant routine follow-up for those living donors who did donate their kidneys or livers. And then deceased donor hospital services. So these are outside of the transplant program, but being a transplant center, those charges related to deceased donors within your hospital are also included as organ acquisition costs. And we'll discuss that a little bit later. And then finally, the indirect or overhead costs. So space-related costs related to the staffing, the pre-transplant administrative component of direct costs, their employee benefits, the hospital overhead with administrative in general, cafeteria costs, medical records, nursing administration, and then sometimes social services. You have social workers that are involved in the transplant process. They may be included in a different department. So what are costs that are considered not allowable for organ acquisition? The first 5 components are specific within the CMS manual, and these services they are reimbursed, but they're just not reimbursed through organ acquisition and Medicare cost support. These are billed to the particular payer, including Medicare, and obtained according to the methodology for that payer. The final 2, the transportation cost of the living donor, as well as the UNOS required follow-up visits for those living donors, those can be institutional costs, but we just cannot claim that on the Medicare cost support for organ acquisition reimbursement. This next slide is just a simple overview then of how Medicare reimburses for organ acquisition. We talked about the organ acquisition costs. If you take that irrespective of payers, so this is all payers, multiply it by the ratio of Medicare usable organs to total usable organs, and that's what Medicare is going to pay. So they won't pay the 100% of the organ acquisition costs unless 100% of your total usable organs were Medicare, but they will pay their share of it. So what are the financial risks related to Medicare reimbursement for organ acquisition? Well, obviously you do have that risk of over-reporting, meaning you've claimed costs that you should not have claimed, that don't meet the definition of organ acquisition, or under-reporting, which is really the common case, that we're not including costs that are considered organ acquisition because of the complex systems that are needed to capture the appropriate information. So it does require internal controls to make sure you're not over-reporting, and those proper systems to capture the appropriate documentation. And of course, we're doing all of this to maintain compliance with CMS regulations and guidelines, in addition to appropriately capturing reimbursement. So from a regulatory compliance standpoint, back in September of 2006, the Office of Inspector General, which is under the Department of Health and Human Services, did a review of organ acquisitions costs claimed by certified transplant centers, understanding that this was a very complex area. So the scope of the review, they looked at 11 transplant centers across the country based on their cost reports that were filed between 2000 and 2004. Of these 11 transplant centers, $203 million were claimed for organ acquisition costs, and Medicare reimbursed roughly half of that amount, at $105 million. So what were the findings from the OIG? Well, of that amount, roughly $47 million were unallowable or unsupported costs, and Medicare's share of those unsupported costs was roughly $28 million. Examples included the transplant centers did not apply reasonable compensation equivalents, or RCE limits, to physician compensation. So CMS does set specific limits as to what is considered reasonable for physician compensation, and those centers did not apply those limits. Centers also claim costs for post-transplants or activities that were not even transplant related. And then the documentation was not current. Information was based on prior years, for example. Now, where were the response from transplant centers? And I'm not surprised because of the complexity of this area, but they lacked understanding of what the Medicare requirements were for claiming organ acquisition. And they also were unaware that they had claimed unallowable costs for Medicare reimbursement. The transplant centers acknowledged that they did have inadequate systems to identify, allocate, document, and claim properly the organ acquisition costs for Medicare reimbursement. So now I want to talk about what are the key reimbursement drivers. And so there are two. The first is the organ acquisition costs, and the second is the Medicare ratio. So I'm going to talk about the key reimbursement driver number one, or organ acquisition costs, and the common findings from my reviews of Medicare cost reports. What I had found is that transplant centers weren't capturing the hospital physician diagnostic evaluation charges for living donors and recipients for all payers, meaning that they may have only been capturing these for Medicare patients. Understanding the formula where Medicare pays their share of the total cost, if you exclude the non-Medicare patients, then you're diluting your Medicare reimbursement when you're applying that Medicare ratio. Transplant hospitals were not also capturing the charges related to deceased donors because this is outside of transplant, so this requires collaboration and communication with the organ procurement organization as well as the hospital's OR team to identify those charges. The time surveys for personnel were not completed within Medicare guidelines, and Medicare does have specific guidelines as to what is considered an appropriate time survey. Personnel who are in non-transplant departments were also not captured. As I mentioned, they may be like social workers, they may be in a different department altogether. So there may be some opportunities to reclassify their personnel salaries and benefits into organ acquisition. And then the organ overhead statistics related to organ acquisition just were not current. They're based on prior years, or they just left them off altogether from the Medicare cost report. This next slide just shows an example of how underreporting organ acquisition costs can hurt a transplant hospital financially. So in this case, the organ acquisition costs originally reported were $12 million, but if, let's say, they missed the deceased donor charges or did not include charges related to their non-Medicare prospective living donors and recipients, and it would have been $16 million. And assuming their Medicare ratio is the same, so the Medicare ratio of total usable organs was 80%, and the original Medicare would have reimbursed around $9.6 million, but the other $4 million now being included in the full cost, if they included it, the additional reimbursement would have been $3.2 million because Medicare is paying 80% of those additional costs. Moving on to key reimbursement driver number two, which is the ratio of Medicare usable organs to total usable organs. So this is key. The definition of Medicare usable organs to total usable organs is through these buckets. Primarily, the Medicare Part A primary transplants and the total transplants are included. But transplant centers forget to include the secondary transplants. And Medicare had to have some type of liability, and this is also covered in the Provider Reimbursement Manual, Chapter 31. Organs that are sent to the OPO, your organ procurement organization, so these are deceased donor organs that I talked about earlier, and outside of transplant, but because you are a certified transplant center with Medicare, you can include those, and those are considered Medicare usable organs, are included in both the denominator and the numerator. Organs sent to other transplant hospitals. So commonly, this is with paired kidney exchange, where you're a donor hospital and you're sending for example, a kidney donor to another transplant hospital. or if you are working with a children's hospital and the adult donor nephrectomy occurs at your hospital, and then you're sending the kidney over to the children's hospital, those also are considered Medicare usable organs to be included in both the numerator and denominator. So the common findings from my review of Medicare cost reports were hospitals were including Medicare Advantage transplants as Medicare usable. Medicare Advantage is paid under Part C of the trust fund, and it's not and the Medicare cost support is under Part A. So only the traditional Medicare transplants are included in Medicare usable. The Medicare Advantage is treated as a non-Medicare transplant. Transplant centers also failed to document that a transplant was actually paid by Medicare Part A, understanding that the recipient's primary payer may change from the time that they had originally listed to the program, even to the time of admission, to eventually finding out that Medicare either didn't pay or maybe actually did pay as Medicare Part A. So really documenting who paid for that transplant. There was no determination if Medicare Part A transplant qualified as secondary. Sometimes I've seen where transplant centers included all Medicare secondary transplants in the Medicare ratio, but there was no determination that Medicare even had a liability for that claim. So you do have to go through a separate test. The live donor organs procured for kidney pair donation and sent to another transplant center, those were excluded, and we had talked about that in the previous slide, and excluded live donor organs procured and sent to a children's transplant center. Organs that were related to deceased donor procured as usable and so to the OPO were also excluded. Those are going to increase your Medicare ratio. So on the next slide, let's show the financial effects of the not including the OPO organs that you send to the OPO that are considered procured as usable. So assuming the Medicare or the total organ acquisition costs are the same at $16 million, and the Medicare usable to total usable without the OPO organs were 80% or 80 over 100. But if we included the 20 deceased donor, let's say it was deceased donor kidneys into the Medicare ratio, now our ratio has increased from 80 to 83.3, so 100 over 120 as opposed to 80 over 100. So now Medicare is going to reimburse at $13.3 million versus the $12.8, or a difference of $528,000. So this example is assuming it from one organ, and if you're certified for several organs, you can see how this can impact your Medicare ratio. And then finally, I want to talk about what are the keys to financial success of an organ transplant program. With Medicare reimbursement being the focal point, these outer circles here are really important, that we have this communication and collaboration between all of these departments. For example, properly accounting for the costs related to organ acquisition, related to the separate organ acquisition components. If they're located in a different part of the general ledger, then those who are preparing the Medicare cost report are not going to be able to obtain or properly report that on the Medicare cost report. Next is the organ procurement organization. As I mentioned before, really identifying who those donors are, deceased donors, how much was paid by the OPO to your hospital, who are those donors, and which organs were procured, so we can include that in the Medicare account. Transplant administration, really understanding who were the transplants, what are the accounts, who were the recipients, who were the living donors, how many were through paired kidney exchange, and who did we do those paired kidney exchange transplants with. Revenue cycle is then looking at, are we capturing the services for all of our population related to organ acquisition, both Medicare, non-Medicare, donors, recipients, and so forth. And then how are we properly billing for those services and capturing those for the Medicare cost support. And then managed care contracting. They may not have a direct benefit to Medicare reimbursement, but they should understand how Medicare reimburses for organ acquisition and how that impacts managed care contracting, because there may be based rates on the Medicare reimbursement or the Medicare cost support, and follow that Medicare reimbursement methodology. So really understanding how do your managed care or your non-Medicare payers reimburse for organ acquisition is the key. And then finally, these are the references that I've provided where you can find some more information on the reimbursement for organ acquisition. So in closing, I hope that this presentation was informative and helpful for you to understand the importance of Medicare reimbursement for organ acquisition costs. Thank you.
Wow, Robert, that's some great information. So if our viewers have questions for you, are they able to get in contact with you by email?
Absolutely, either through email or if they want to give me a call. I know my phone number is not provided, but I'll be happy to answer any of their questions related to this complex topic.
Excellent. Well, thank you very much. So we want to thank you again for your time and for this excellent presentation today. The Transplant C-Suite Snapshot and the Webisodes are a biannual publication of the Alliance, so you can find more of these resources for free on our website at organdonationalliance.org/C-Suite. Now, we also want to extend our thanks once again to Mr. Robert Howey for your time and for an excellent presentation, and our thanks to our viewers for watching. We wish you a great rest of your day. Take care.